skeleton. So we're at the pelvic girdle and the legs, the lower limbs. Pelvic girdle is also called the hip girdle. It is formed by two bones called the coxal bones, or very commonly the os coxae, as well as the sacrum. Attaches the lower limbs to the axial skeleton with very strong ligaments, transmits the weight of the upper body to the lower limbs, and supports our pelvic organs. It is less mobile but much more stable than the shoulder joint, we'll see, even though they are both ball and socket joints. Those coxal bones are formed by the fusion of three bones, the ilium, the ischium, and the pubis. The socket where the femur will fit into this structure is called the acetabulum. It's a much deeper socket than we had in the shoulder, and on top of that, it's a lot of soft tissue holding the head of the femur in. We can see it here. So the ilium is the superior region of the coxal bones. It articulates with the surface of the sacrum, forming the sacroiliac joint. The ischium is the lower toward the rear part of the hip bone, and the pubis is the front part of the hip bone. And the two pubis bones join each other at a fibrocartilaginous joint called the pubic symphysis. So the ilium has a body and wing-like structures we call the ala. The iliac crests are thickened superior margins of the ala, and the iliac crest ends at the anterior superior iliac spine and the posterior superior iliac spine. The greater sciatic notch is where the sciatic nerve passes through. The gluteal surface has three ridges: posterior, anterior, and inferior gluteal lines. Those are places where the gluteal muscles will attach. The iliac fossa has a concavity on the ala. The auricular surface articulates with the sacrum, and the accurate line defines the pelvic brim. The ischium has a body and a ramus. Think of the side of the mandible, and when you hear ramus. There are three important markings on here: the ischial spine, the lesser sciatic notch, and the ischial tuberosity. The pubis is a V-shaped structure in the front, consists of a body and superior and inferior pubic rami. Again, there's those rami-shaped structures. Anterior border forms the pubic crest. The lateral ends form the pubic tubercle. There is a large opening here called the obturator foramen. And the pubic bones join at the pubic symphysis, and they will form a pubic arch or subpubic angle. And this is one of the main differences between male and female pelvises. We will be looking at that in the lab on Thursday. So the major differences between the male and female skeleton are all related to the process of childbirth. And in the pelvis, we see some important general differences between male and female. So the female pelvis tends to be wider, shallower, lighter, and rounder than a male's. The pelvic brim, or the pelvic inlet, is a continuous oval ridge that runs from the pubic crest to the accurate line to the sacral promenade. The false pelvis is above the pelvic brim. The true pelvis is everything below the pelvic brim, and that defines the birth canal. And the pelvic outlet is the lower part of the true pelvis. So here we see some of the differences pointed out between female pelvis, and then we see the comparison with a male pelvis. So this pubic arch is a good way to tell. You can also see some of the differences in the other places. So now we're at the lower limbs. The lower limbs carry the weight of a standing up, erect body. They're subjected to exceptional force during things like running and jumping, and it's divided into three segments, much as the upper limbs were. Here we have the thigh, the leg, and the foot. So the thigh is made up of the femur bone. It's the largest and strongest bone in the body. It makes up about a quarter of a person's height. So if you know the length of a femur, you can multiply that by 4 and get an approximation of a person's height. It articulates proximally with the acetabulum to form the hip joint, and distally it articulates with the tibia and the kneecap, the patella. And that patella, again, is a sesamoid bone in the quadriceps tendon that helps protect the knee joint. Some of the structures on the thigh bone include the fovea capitis, which is a small pit and a ball-like head, greater and lesser trochanters, where muscles attach. They're connected to each other by an intertrochanteric line and crest. The gluteal tuberosity blends into the linea aspera and diverges to the medial and lateral supracondylar lines. Distally, the femur ends in the lateral and medial condyles that articulate with the tibia, not the fibula. The medial and lateral epicondyles are sites of muscle attachment. The adductor tubercle is the medial epicondyle bump. The patella surface articulates with the patella, and the intercondylar fossa is between the condyles. And all of those are pointed out here. We get down to the leg. We've got 2 parallel bones, the tibia and the fibula. They're connected by an interosseous membrane, similar to what we saw between the ulnar and the radius. Tibia is the medial leg bone. It gets the weight of the body from the femur, transmits that to the foot. The fibula is not part of the knee joint. It is not a weight-bearing bone. It has several muscles that originate from the fibula. It articulates proximally and distally with the tibia, so on both ends. Features of the tibia would include the medial and lateral condyles, the intercondylar eminence, the tibial tuberosity, the anterior border, the medial malleus, and the fibular notch. And on the fibula, we have the head, the lateral malleus, again pointed out in these structures, including that intraosseous membrane. A bimalar fracture is a break in the distal ends of both the tibia and the fibula. A common sports injury would probably be described as an ankle break. And here is an x-ray. Nope. Here is the x-ray, and I can't make it any bigger, sorry. Down in the foot, we have tarsal, metatarsal, and phalanges. The tarsus are the 7 tarsal bones that form the back half of the foot. Body weight is primarily carried by 2 of these, the talus and the calcaneus, which we would refer to as the heel. The calcaneal tuberosity is the part that touches the ground. Substancular tali or talar shelf supports the talus. Other tarsal bones include the cuboid, navicular, medial, intermediate, and lateral cuneiform bones. The metatarsals, there are 5. We'll go 1 to 5, starting with the big toe, known as the hallux, to the little toe. The enlarged head of the metatarsal, number 1, forms what we call the ball of the foot. And again, we have phalanges, much as we did in the hand. So there are 14 in the toes. The first one, digit 1, the great toe or the hallux, has a proximal and distal phalange, no middle one, while the rest of them, like the fingers, have 3 bones, distal, middle, and proximal phalanx. And they are shown here. There are some arches that are important to the way the foot works. They're maintained by the interlocking foot bones as well as ligaments and tendons. They help the foot to bear weight. 3 are the lateral, medial, and transverse. The lateral is a low curve that elevates the lateral part of the foot, while the medial arches curve upwards. and the transverse runs obliquely from one side to another. So here we have the medial, lateral, and then longitudinal, transverse running in this direction. And there's the normal X-ray, as far as I can tell. A flat foot, or pes planus, called fallen arches at times, is a congenital condition or may be acquired later in life. It can be caused by increasing age, obesity, high impact activities. Proper footwear with good arch support can help prevent the problem. That would include orthotic shoe inserts that can help manage symptoms. All right, that pretty much covers what we've covered. Now we'll talk a little bit about development. This infant skull has more bones than the adult skull. We mentioned that before. Skull bones are connected by fontanelles, the anterior, posterior, mastoid, and sphenoid. Congenital abnormalities can distort the skull. Cleft palate is the most common of these conditions. There's no medial fusion of the left and right halves of the palate. That can interfere with sucking. Can lead to aspiration of food into the lungs, which may result in aspirational pneumonia. Here are images of a cleft lip and palate, and then following the repair, surgical repair. At birth, the cranium is huge relative to the face. At 9 months, it's about half adult size. The mandible and maxilla are foreshortened but lengthened as we get older. Arms and legs grow at a faster rate than the head and the trunk, which leads to our final adult proportions, mapped out here in just the skull and here over the course of life. So the primary curvatures of the thorax and sacrum are convex at birth, which we start with a C-shaped spine. Then we develop the cervical and lumbar regions, give us our gentle S-shaped spine. And here is an example showing the C-shaped curvature of a newborn. As we get older, intervertebral discs become thin, less hydrated, less elastic. We get a higher risk of herniation. We can lose several centimeters by age 55, and 1 inch is 2.5 centimeters, so we're roughly talking an inch. Costal cartilages tend to ossify, so they become more fragile. It also can interfere with breathing. And all of our bones are going to lose mass, so the risk of fractures increases. And that brings us to the end.